We might get started. There doesn't seem to be more people coming in for now. Okay. So, hello and welcome to the Australian Action on Preeclampsia second webinar for this year. I'm very pleased that you've joined us tonight for what's going to be an excellent webinar. My name is Lynn Roberts. I'm the president of APEC, and I truly welcome you all here tonight. On behalf of APEC, I'd just like to do an acknowledgement to country, because Australian Action on Preeclampsia acknowledges the traditional owners of country throughout Australia and acknowledges their continuing connection to land, waters and community. We pay our respects to the people, the cultures and the elders past and present, and extend this respect to all First Nations people with us tonight. So the webinar tonight's been put together based on feedback we've received from previous webinars. So you all asked for some information on fetal growth restriction, so we're going to give it to you tonight. We have three excellent speakers with us tonight who are going to let you all know about FGR, monitoring it in pregnancy, and also the short and long-term outcomes for the infant. So I will introduce each speaker separately just before their presentation. But so as to not disrupt the speakers tonight, those in the audience have their cameras turned off and their audio has been muted. So if you are very welcome to ask questions, but we ask you to type them into the Q&A box, which is down the bottom of your screen, in between the share and the show caption boxes. So I'd like you to introduce Cami. Give a wave, Cami. Cami's the APEC secretary. She does a brilliant job in that role. She was looking after the technical side of tonight, and she will also be monitoring the Q&A box for the questions. So please go ahead and type them in there when they spring into your mind. So I'd now like to introduce our first speaker to you, Associate Professor Julia Unterscheider. Julia is an obstetrician and the director of the birth centre at the Royal Women's Hospital in Melbourne, Australia, which is the largest single-site maternity hospital, and they have over 7,500 births every year. So Julia was born in Austria, trained in Ireland, and she's worked at the Women's since 2014. Her PhD was on a topic of fetal growth restriction and gave new insights into the definition, direction, and monitoring of this common problem. She's passionate about supporting families through their childbirth experiences and medical and midwifery colleagues in managing the challenges of modern obstetrics. So I'm very pleased to introduce Julia this evening. She'll be talking about the detection of fetal growth restriction and the monitoring and management of the pregnancy. So big welcome to Julia. Thank you.
Thank you so much, Lynn. I'm just going to share my screen, and it's very exciting to be here with you all tonight. So I'm going to talk about fetal growth restriction and some of the connection, obviously, to preeclampsia, as we're here with APEC. I would like to acknowledge country as well. So acknowledging the Wurundjeri people of the Kulin Nation. This is the site on where the hospital stands and where I'm presenting from today. I also want to give a bit of a trigger warning and an acknowledgement of lived experience, and the presentation will certainly discuss pregnancy loss related to fetal growth restriction. And I just want everyone to be mindful that some of the content may be confronting and difficult to hear. And by sharing this information, I honor the infants and families who are affected by these events with the commitment to learn, improve and create systems which allows safe care for women and their babies. And I will use the term woman and women throughout this talk, and acknowledging that not all people who are pregnant and give birth are identifying as women. So what will this talk cover? This talk will cover what is fetal growth restriction, what influences fetal growth in utero, why detection of fetal growth restriction matters and what we can do to improve the rates. Then I'll take you through definition and diagnosis, which cutoffs to use and when to worry, and the management of fetal growth restriction when it is identified. So talking about ultrasound surveillance and delivery indicators. This is a bit of a tour de force in 15 minutes, and I hope you bear with me when I take you through, and I hope I be able to explain it all to you. So what is fetal growth restriction? Fetal growth is a complex interaction of many factors that determines how the baby grows in utero. And it can be inherent problems within the baby itself, with the placenta, with the mum, so with risk factors coming into the pregnancy, which are obviously overt to us, and environmental factors such as heavy smoking or drug use. And we know that all of these factors interact to create the optimal environment for this baby to develop, but that some factors might influence that the baby does not grow as well. Some of these factors might not actually be apparent until the baby is born and we're able to examine the placenta. So it's important to acknowledge that this is overlapping and that this might be multifactorial, and this might only come to light when the baby is born. So fetal growth restriction is common and quite complex because of these multiple factors influencing how a baby grows, and it's affecting about 10% of pregnancies that we care for. So it's our bread and butter. Fetal growth restriction is diagnosed when the baby falls below the 10th percentile for the gestation in weight and does not achieve their full growth potential. And you might hear terms that are used interchangeably with fetal growth restriction, so FGR, SGA, small for gestational age, or IUGR, intrauterine growth restriction, are all terms that are used for sometimes one and the same situation where the baby is just small and not thriving as we're expecting it to be. So growth restriction can occur early, and that's usually defined if it occurs prior to 32 weeks gestation, and it can be late when it occurs after 32 weeks gestation. And it can come together with preeclampsia as a placental syndrome, or it can come without. And it can often go unnoticed, and it occur in women without any risk factors. So this is where the challenge lies. I want to take you through just this slide in terms of early and late fetal growth restriction. So for reference, a pregnancy is 40 weeks, and usually a baby can survive after 22 weeks or when it has reached 400 grams. And for reference, we really, these are two different diseases really. Early onset growth restriction is commonly associated with placental disease, preeclampsia. We know that we can use Doppler ultrasound. It is commonly detected on ultrasound because we do a morphology scan for every pregnant woman around 20 to 22 weeks. So this is where it commonly gets detected, or when it comes with high blood pressure. So someone has high blood pressure at 25 weeks and we'll go looking for the growth of the baby because we know it is associated with each other. The biggest problem is probably the late onset growth restriction because it happens after 32 weeks. We're not scanning all pregnancies. We're relying on measurement of the mom's abdomen, and it often goes unnoticed. It doesn't come with high blood pressure. It doesn't come with anything else, and it just randomly appears in women that have no risk factors. So why does it matter that we detect growth restriction? So a healthy pregnancy with a healthy and well-grown baby confers a risk of stillbirth, about 1 in 500. So it is quite a low risk of anything going wrong. But when we have a pregnancy that is associated with fetal growth restriction, and in particular, if the growth restriction goes undetected, this risk goes up significantly to affecting about 1 in 50 pregnancies being affected by stillbirth. So it is really important that we detect it, because if we detect it, we can manage it and we can indicate delivery. It might result in early delivery, but we're able to manage it, and we're going there with open eyes and managing the pregnancy with open eyes. So the first case I want to present to you is Anna. She's a 26-year-old, very healthy primary gravida. So in her first pregnancy, she's a regular attender and has normal blood pressures. And she presents at 29 weeks with reduced movements. And unfortunately, a fetal death in utero is diagnosed, and the baby is expected to be really small. And indeed, after induction of labor, she gives birth to a baby that is 716 grams. The expected birth weight at this gestation would be 1.4 kilograms. So there were no red flags for this woman. There were no risk factors for this woman, and she had an undetected severe early fetal growth restriction that resulted for her baby to die. We examined the placenta. It confirmed that the placenta was quite small and that it had multiple areas of infarction. Given this information, this woman is now pregnant. She's attending my pregnancy after loss clinic. She's 34 weeks today. She's on aspirin, and her baby is already 1.9 kilograms. So with preventative measures and appropriate care in a subsequent pregnancy, we can change the trajectory of a pregnancy. And this highlights the problem with antenatal detection, because what do we do in routine care? We're going to do a morphology scan at 20 to 22 weeks, and then usually we just measure a maternal abdomen by a tape measure. So we put the tape measure on someone, and we can imagine that we're measuring maternal fat as well. So, you know, in women who are overweight or obese, this is a big problem. And we know that fundal height measurement only detects about 20 to 30% of growth restriction. We also know that risk factor-based screening, so this is the table on the right-hand side where women come into the hospital, you take a comprehensive history, and then you classify them as risk stratify them into FGR level 1, 2, or 3 risk, and then you institute ultrasound surveillance. We know that 50% of the growth restriction happens in women without any risk factors. So this is a very imperfect strategy to detect fetal growth restriction. And we do a lot of unnecessary scans for women with risk factors that will never have a growth restricted baby. So then there's the question, should we do scans for everyone? At 28, 32, and 36 weeks, we know the longitudinal growth of the baby gives us a lot of information. And certainly these strategies improve the detection of fetal growth restriction, but it also detects false positive diagnosis. So it means that we sometimes diagnose a pregnancy as worrisome, where nothing was actually wrong, and we would then intervene and do an induction of labor or a cesarean section where it might not have been necessary. And probably the answer is that we need to focus on early pregnancy, do multimodal assessment with biomarkers, with ultrasound, with maternal risk factors, and put it all together. But this is currently not in practice around the world universally. So moving on to definition and diagnosis. As I said to you, the definition is a very arbitrary cutoff of the 10th percentile. We know that fetal growth restriction presents a continuum of disease. So the babies that are smallest, so under the 3rd percentile, under the 1st percentile, are the ones that might be sickest. And we also know that babies that are, so we know that not all babies that are under the 10th percentile are unhealthy babies. So they might be well. They might just be small, but are growing and showing growth in utero until the birth, where we can actually continue the pregnancy to 38, 39, 40 weeks even. And we also know that not all babies that are well are over the 10th percentile, because if you are, for example, destined to be born on the 90th percentile, so you're destined to be a 4-kilogram baby and you're born as a 2.5-kilogram baby, you might actually be growth restricted and unwell, and might just be at risk of, stillbirth and morbidity after birth. So the 10th percentile is a very arbitrary cutoff. We need to always really take all the factors that come into play: ultrasound information, clinical information. It gets even more complicated when we talk about charts. So plotting findings, fundal heights, ultrasound measurements against charts. There's customized charts that take into account maternal, height, weight, ethnicity, what sex the baby is. We know boys might be bigger than girls. Indian women might be having a smaller baby than a Caucasian woman, for example. We currently use population-based charts. So we measure every woman, irrespective of how she comes into pregnancy, over the same standard. And we know that we have estimated fetal weight charts, so based on ultrasound, and we have birth weight charts. So it's quite complicated. There's hundreds of charts out there, and we need to compare like with like when a pregnancy progresses. When to worry is when growth restriction happens really early. So when you are faced with decisions at the borderline of viability, where someone might need to make a very difficult decision to terminate the pregnancy if there's severe preeclampsia and very severe growth restriction, where we know that this pregnancy will never reach the viability. So it will never go above the 400 grams. And this is really tricky, and this is very difficult. And we also know that extreme preterm birth, 24, 25 weeks, when you have a growth restricted baby, can pose huge challenges for the baby. And you'll hear from my co-speakers later on what it means for a baby to be born so small. We do worry when there is poor interval growth velocity. So when we assess growth every 2 to 3 weeks and the baby doesn't grow well, we do worry, because if there's a fall off of growth, it might mean that the baby is not in ideal intrauterine conditions. We do Doppler ultrasound. So once we know that a baby is small, we have the opportunity to actually assess some of the blood flow patterns in the umbilical artery, in the middle cerebral artery, which is in the baby's brain, in the ductus venosus. So these are the 3 main vessels that we would interrogate if we have a small baby, to inform us how long a pregnancy can continue. We take clinical events very seriously. So, someone who's presenting with bleeding, so vaginal bleeding or reduced movements, or indeed evolving preeclampsia, all these things play a role in always considering the total clinical picture, knowing that things can be dynamic and change over time. So case 2 is Sarah. She is a 24-year-old G5P0. She's had 4 recurrent miscarriages in the past, and she's diagnosed with severe early onset growth restriction at 23 weeks. She presents at 26 weeks with an antepartum hemorrhage, so she has some vaginal bleeding. The CTG is put on, it is abnormal. She has a consultation with a neonatologist and an obstetrician, and together we make a shared decision to go ahead and deliver the baby by classical cesarean section. Just a bit of a more tricky cesarean section that has an incision up and down on the uterus. The baby is born weighing 380 grams, so this is very much at the cusp of when survival is possible. And the baby spends 122 days in our NICU and survives with health issues that are related to the premature, in particular some lung issues and some feeding issues. And we thankfully examined the placenta. The placenta showed massive paravenous fibrin deposition, which is a very unique finding in severe growth restriction. And we know that we can give treatment in a subsequent pregnancy to prevent this from happening again, because this is a lesion that can come back in a subsequent pregnancy. So it's very important to always have a follow-up with the placenta as well. So how do we manage fetal growth restriction when we know it? So once we detect it, we actually have quite a good management algorithm, and I'm bombarding you with this now. This is just the algorithm that we use when a baby is small. What do we do? So we would do growth scans every 2 weeks to inform us about the interval growth velocity of the baby. Each time we scan you, we would do an umbilical artery Doppler, a middle cerebral artery Doppler. In early growth restriction, we rely on the ductus venosus blood flow as well. And we have quite clear definitions and cutoffs of when this would indicate delivery. And it's very much based on the blood flow in the umbilical artery, so in the cord of your baby. And we use additional, you always put everything together. How are the movements? How is the clinical situation? What is the blood pressure doing? And that would really, indicate delivery. So we use ultrasound, we use CTGs, we use clinical assessment. And this case highlights, so this is my last case for today. So Ayman is a 40-year-old G2P0. She develops high blood pressure at 30 weeks. So this is our prompt for giving her a growth scan. Her baby's on the 15th centile at 31 weeks. And then she has a repeat scan. Her blood pressure remains quite stable. She has a repeat scan that demonstrates that this baby hasn't really grown that well. So it dropped from the 15th centile to the 3rd percentile at 33 weeks and has shown us some raised umbilical artery blood flow, which means that probably the placenta is not working that well. In addition to this, and very commonly, it concurs with preeclampsia, which worsens. She's admitted to the hospital, her antihypertensive, so her blood pressure medication is increased. She's getting some antenatal corticosteroids because we anticipate that this baby might be born preterm. She has regular scans and CTGs, and a decision is made because the Dopplers deteriorate and the preeclampsia deteriorates, and she has a cesarean section at 34 weeks, and a live male infant is born weighing 1.7 kilograms. And Rocco will take you through the immediate care of this kind of baby that you might expect, and will be in the neonatal intensive care for a little while. So considerations for delivery are always based on trying to get this baby to survive. Once it survives, to reduce the morbidity that this baby might be experiencing, and after a certain gestation to gain maturity. So it's really trying to prolong the intrauterine life as long as possible. But when we feel the baby is in a hostile environment where the risk of stillbirth outweighs the risk of the baby being born and going to the neonatal intensive care unit, while we recognize that a delivery can sometimes be a quick decision, which leads to a lot of sequelae going into the neonatal unit, this is a very careful decision we make together with the parents, with the neonatal colleagues, and we don't take it lightly. We take it lightly once you're 38 weeks, but we're definitely not taking it lightly anytime before 37 weeks, and every day in utero matters because, because of the morbidity that is associated even with late preterm birth. We do take that very seriously. And I want to just say that the placenta tells a story. So it's really important that if a pregnancy is affected by severe preeclampsia, by severe growth restriction, that we send it to our pathologists. We have excellent pathologists who can really interrogate the placenta and give us a finding, and it might really influence what we do in a subsequent pregnancy, because we know these are all really big words on there: high-grade velitis of unknown etiology and chronic histiocytic intervillositis. But some of these findings really matter because they have a high risk of recurrence in another pregnancy. They need treatment in another pregnancy, so at least with low-dose aspirin, sometimes with Clexane injections, sometimes with prednisolone. So it's really important to really review this after someone has had a preterm growth-restricted preeclamptic pregnancy. And this is my whole presentation in one slide. So I'm going to leave you with this, but basically this is kind of a quick review on growth restriction and what we do with it, and that we always try and take great care of you and your baby throughout the pregnancy. And Rocco and I, we've written a paper on early onset fetal growth restriction. And what we have put in there is really that this thing of when we do the counseling with parents, it is very evident that everyone likes everything done, and that all decisions, even if they are to say, I'm having palliative care, are made out of love, and that we as clinicians need to really help our patients and our families that we look after to unravel this doing everything, and that doing everything doesn't always mean to be active and deliver an extremely growth restricted infant, because it does have an impact on your life going forward. And I thank you very much for listening, and I'm looking forward to your questions and the other speakers as well.
Thank you, Julia. That was a really lovely, concise presentation. Cami, are there any questions in the Q&A box? We don't have a lot of time, so maybe if we can just choose one.
There weren't. There were some that were pre-submitted, but can also leave them to the end if you prefer.
Yeah, we might leave them to the end to see how we go for time, if that's all right. So we'll move on to our next speaker, and Julia has half introduced him anyways, being her colleague, Dr. Rocco Cuzzilla. He joined the Royal Women's Hospital in Melbourne as a consultant neonatologist in 2015. He finished his training in Melbourne and also did some components in Toronto in Canada. His PhD explored the use of cranial ultrasound to predict outcomes for babies born very preterm. So he has an interest in neonatal neurology, fetal medicine, and medical education. He also holds a clinical senior lecturer position with the University of Melbourne and an honorary research fellow position with the Royal College of Surgeons in Ireland, which is where he is at the moment, coming to us from this morning in Ireland time. So a huge thank you to Rocco. It's a big effort to join a webinar when you're away with work on the other side of the planet. So please welcome Rocco, who'll be talking about the immediate care of the newborn with fetal growth restriction. Thanks, Rocco.
Thanks, Lynn. It's a real pleasure to join the webinar. I really appreciate the invitation. I am going to be asking Cami to change slides as we go through. I apologise, just having some difficulties with sharing from this end. So thanks, Cami. Julia's really laid the groundwork for the presentation that I'll be presenting now. So I might skip over some of the background information, but perhaps highlight the salient points as they relate to outcomes for newborn babies. So as Lynn has introduced me as a neonatologist, I thought I'd just share with you what that is. It's a specialist paediatrician for newborn babies, including babies born very preterm and any other babies needing specialist care from birth. So both Arvind and I are neonatologists working in Melbourne. Next slide, please. So as Julia has pointed out, fetal growth restriction, or FGR, is a common presentation in obstetrics. It's really their bread and butter, affecting up to 10% of all pregnancies. It's a condition that relates to faltering growth of the baby in utero, whereby the fetus does not meet their expected genetic growth potential. It's different to small for gestational age or small babies, which merely describes a baby whose estimated fetal weight is generally less than the 10th centile for that particular gestation. FGR is demonstrated here on this growth chart with estimated fetal weight on the y-axis and gestation in weeks on the x-axis. And you can see there repeated ultrasound estimates of the fetal weight represented by the red dots showing a slowing weight gain over time, such that, for instance, at 32 weeks, the baby is measuring smaller than is expected for that gestation. Next slide. Although it's important to highlight that not all growth charts were created equally. The chart on the left is the Hadlock chart that's mostly used in pregnancy by obstetricians and midwives alike to assess fetal growth. It was derived from a large cohort of healthy singleton pregnancies where cross-sectionally these pregnancies had an estimate made of fetal weight using a number of biometric measures, including a couple of the head circumference and a biparietal diameter, and a measure of the abdominal circumference and a measure of the femur length. The chart on the right is the chart that Arvind and I use in the nursery. It's a chart that we use called the Fenton chart for babies who are born preterm. This chart was derived from a large cohort of many thousands of preterm babies born at different gestations and for all sorts of reasons, but not from healthy pregnancies. So the two cohorts are very different, represented in these two charts. And what these charts really highlight is the significant difference between growth charts used before and after birth. For example, at 32 weeks gestation, an obstetrician may be concerned for a small baby just under the 10th centile with an estimated fetal weight of about 1,600 grams. After birth, the same baby with a birth weight of 1,600 grams is considered well grown on the Fenton chart, just under the 50th centile. What happens to the developing baby in the womb is important for us neonatologists in managing these babies from birth. This is particularly true of the FGR newborn, because otherwise the FGR newborn and their particular risks may be under-recognized by the Fenton charts we use in the nursery. So history here, history of FGR, is really important. Next slide, please. As Julia has highlighted, FGR is not one disease, but rather a presenting problem which can have one or many causes. And the causes are not always immediately apparent and sometimes can only be identified after the pregnancy has ended, with further testing of the baby and a thorough look at the placenta under the microscope. Uteroplacental causes account for the vast majority, about 3/4 of all cases. And uteroplacental causes of FGR include hypertensive disorders of pregnancy, such as preeclampsia, maternal morbidities, just like chronic kidney disease or chronic cardiac disease, and placental disorders. The remaining causes include major structural anomalies, chromosomal or genetic abnormalities, or congenital infection. And we must all remain circumspect, as a uteroplacental cause of FGR can coexist with any other non-uteroplacental cause. The remainder of my talk, though, will focus on preeclampsia as the cause of FGR and its particular implications for the health of the newborn. Next slide. Preeclampsia, however, does not always lead to FGR. About 25 to 45% of preeclampsia is associated with FGR, with greater risk of growth restriction with an earlier diagnosis of preeclampsia. Uteroplacental causes like preeclampsia lead to FGR through a common pathway. Placental dysfunction or insufficiency disrupts the normal supply of blood with oxygen and nutrients to the developing fetus. Chronic fetal hypoxemia, that is reduced oxygen levels in the fetus, and malnutrition cause stress to the fetus, leading to changes in the way their cells tissues and organs develop in both structure and function. Blood with oxygen and nutrients is preferentially directed towards the baby's vital organs, including the brain, heart, and adrenal glands. But even these organs are ultimately affected by the hostile conditions set up in conditions like preeclampsia. FGR is an example of the developmental origins of health and disease, or DOHAD, formerly termed the Barker's hypothesis. This concept describes how adult disease can be linked to how the fetus is programmed in an unhealthy or hostile environment. In this case, chronic hypoxemia, a reduced oxygen supply from the placenta to the baby, and malnutrition due to placental insufficiency lead to changes that predispose the FGR newborn, child, and adult to any number of adverse health and developmental outcomes. Next slide, please. So it's quite straightforward, therefore, to see that FGR is an independent risk factor for many outcomes. It's associated with a high risk of death, and Julia has touched on this. What concerns us all, the risk of perinatal mortality, which can be broken down into two components, that is stillbirth, death in the womb or in utero, or neonatal death, death within the first 28 days after birth. FGR is an independent and frequent cause of preterm birth, that is birth before 37 weeks gestation, which is often indicated on worsening fetal or maternal grounds, or even both in some cases. With an earlier diagnosis of FGR, say for instance early onset, that is a diagnosis of FGR less than 32 weeks, there is at least a 25% chance that pregnancy will deliver by 28 weeks. Another quarter deliver by 32 weeks, and the remainder almost exclusively before 36 weeks gestation. Obstetricians are deciding together with their patients and in consultation with neonatologists the optimal timing of delivery in the fetal interest, balancing the benefits of advancing gestation with fetal maturity without causing further harm, that risk of stillbirth or delivering a preterm baby and all that entails. Preterm birth compounds the risk associated with FGR for major neonatal morbidities, which I'll detail in the next few slides. And it also is associated with adverse neurodevelopment, including a 25-fold increase in the risk of cerebral palsy, and an increase in the risk of cognitive impairment, as well as other long-term adverse health sequelae that I'm sure Arvind will detail further in his presentation. Next slide. So Julia had the case of Anne, and I've got the case of Annie, a 27-week, who's at 27 weeks gestation with a fetus who has an estimated weight of 550 grams. Now, Annie had preeclampsia diagnosed at 22 weeks gestation, based on a high blood pressure that was picked up on a routine clinic visit and confirmed with some clinical signs and perhaps by some blood work. And she's been managed on antihypertensives since 22 weeks with an escalation to now include a few agents, including labetalol. As Julia has described, her pregnancy has been closely monitored with sequential ultrasounds assessing fetal well-being, including Doppler parameters. And now her Dopplers, the baby's Dopplers, at 27 weeks gestation show that there is reversed flow in the umbilical arterial and diastolic flow, and the ductus venosus waveform is now absent. So this baby is showing signs that it isn't coping very well, and there is a considerable high risk of stillbirth. Next slide, please. So with regard to the immediate care of the FGR newborn, we first have to recognise that this has been a high-risk pregnancy since 22 weeks, and the diagnosis has implications for management. Once we know that high risk, we need to mitigate it. This includes surveillance for fetal well-being, as Julia has described, and importantly, a referral to a tertiary fetal medicine unit for multidisciplinary care, combining the expertise of obstetricians and maternal fetal medicine specialists, sonologists and sonographers, neonatologists like myself and Arvind, amongst many others, with the facilities to manage both mother and baby. Next slide, please. We turn to counselling Annie jointly with our obstetric colleagues. Annie knows that her baby is at risk of being born very preterm. In fact, she's known since 22 weeks that this moment could arrive. And she wants to know, will my baby survive if born very preterm? This graph on the right shows survival rates for newborn babies with increasing gestation at birth across different regional and national neonatal networks throughout the world. And it shows increased survival with advancing gestation and reduced variability in survival rates between networks with advancing gestation. This includes all babies, however, born very preterm for any reason, not just the FGR fetus or growth restricted fetus and FGR newborn. So we know that outcomes for the FGR newborn are presumed to be worse compared with the appropriately grown fetus for any given gestation, but quantifying how much worse remains uncertain. When we come to counselling Annie, we know that here in Melbourne and throughout Australia in similar healthcare settings, survival of babies born at 27 weeks gestation is greater than 90%, roughly equivalent to babies born at any gestation from that point on. But we also know that the average baby at 27 weeks gestation weighs 1,000 grams. Survival of an FGR baby born at 27 weeks weighing 550 grams will be significantly lower than 90%. Next slide, please. So we need to optimize the fetal condition for imminent birth, and Annie should receive evidence-based interventions to improve her baby's chances of survival and survival free of adverse outcomes like significant neurodevelopmental impairment. These interventions improve postnatal outcomes, and the timing of such interventions are important. So we would aim to, together with the obstetricians, make sure that Annie's baby benefits from a course of corticosteroids, provided at least 24 hours and up to a week before birth to mature the fetal lungs and reduce the severity of respiratory distress syndrome, reduce the risk of high-grade IVH, that's an intraventricular bleed, a brain bleed, and improve their baby's chances of survival. Annie would also receive magnesium sulfate just before she delivers for fetal neuroprotection to reduce the risk of them developing cerebral palsy. We would ensure that the baby was born in a tertiary centre with neonatologists supporting the baby from the first moments. And the timing of delivery will be, when indicated in the fetal interest, will be about finding that balance between advancing gestation for fetal maturity without causing further harm. Next slide, please. So we assemble our team of neonatal medical and nursing staff. We assign roles to manage the airway, breathing and circulation. We ensure that we have appropriately sized equipment, prioritizing temperature control with what we call a NEO-HELP suit, a polyurethane wrap to keep the warmth in and prevent insensible water losses. We manage the baby in a warm room. We use humidified gases to ensure that they remain warm. We would support delayed cord clamping unless contraindicated. For instance, we know that preeclampsia is associated with an increased risk of placental abruption, so we would say not to proceed with delayed cord clamping in that instance. And we would anticipate that this baby might have a significant respiratory depression and encephalopathy, some brain disturbance, as both are risks in the fetally growth restricted newborn. But maturity is on their side at 27 weeks, so not like a 550 grammer expected weight of a 23-weeker, who we would likely be intubating in the delivery room, a 550-gram 27-weeker may be managed on non-invasive respiratory support, like CPAP, because they might have good respiratory drive. We would then admit them to the nursery with the aim of keeping them pink, warm, and sweet. So that'll just take us on to the next slide, where we manage some common problems and anticipate complications in the neonatal period. So they might have, they are at significant risk of hypothermia and hypoglycemia, low blood sugars, because of those metabolic adaptations in utero. So they have smaller liver and reduced glycogen stores, and this is compounded by their prematurity and sometimes maternal medications, remembering that Annie had been started on a beta blocker, labetalol, which is a medication known to be a risk factor for hypoglycemia in the newborn. There's also less subcutaneous fat and an increased surface area to volume ratio for babies born growth restricted, making them more likely to lose a significant amount of heat and not be able to generate it. I think the biggest threat to survival, however, for the growth restricted newborn born very preterm is a condition called necrotizing enterocolitis. So it's a very serious gut infection that, if warranting surgery, has a very high mortality rate. The other significant risk is sepsis or infection. So we're on the lookout for that from the very, very first hours after babies are born, very preterm. And the next slide just shows the myriad of serious neonatal morbidities that are associated with preterm birth and have adverse implications for babies long term. But the very preterm growth restricted newborn has a significantly increased risk for each of these neonatal morbidities beyond the risk that they already have as a preterm baby. I might just end it there in the interests of time, just mindful of not eating too much into Arvind's time. And I'm happy to answer questions now or at the end.
Thank you so much, Rocco. Yes, I have let you run a bit over time, but it was also interesting, so I just let it go on. Cami, if there is a brief question in the Q&A box, we could probably have time for one. Otherwise, we'll move on.
Similar to before, but there actually is one question. As breast milk already has its own probiotics, why are probiotics used in preterm babies? Is there strong evidence for this, and are there any downsides of probiotics?
Yeah, there's strong evidence for the use of particular probiotics, and one of the largest trials was actually conducted led by one of my colleagues at the Women's Hospital here in Melbourne, called the ProPrem trial, using two particular strains, a bifidobacterium and a lactobacillus, and that combination was shown provided to very preterm babies of very low birth weight to decrease their risk of necrotizing enterocolitis and late onset sepsis. There are other studies that have used other strains of bacteria that haven't shown as good an effect, but the evidence of using these particular two strains is strong, and we use them in our clinical practice.
Thank you so much, Rocco. That was really lovely presentation. So we'll move on to our last presenter tonight, who is Professor Arvind Sehgal. He's a neonatologist, as you've already heard, at the Women's Hospital, and he's head of the cardiovascular research at Monash Children's Hospital in Melbourne. He's completed a PhD while working as a full-time intensivist, and in 2025 completed a higher doctorate in cardiovascular physiology. His current research focuses on the long-term implications of neonatal heart adaptations, and he has more than 150 research papers published in international peer-reviewed journals. So please welcome Arvind as he talks about the long-term health and follow-up of the FGR infant. Thank you, Arvind.
Thank you, Lynn, and thank you to Julia and Rocco. You've done most of my kind of background work, so I'll take it from there. So, we always ask this question about how is it that some of us are prone to chronic diseases like hypertension, diabetes, and stroke. And always there is a list of conventional answers that perhaps it's in our genes, kind of diet we eat, how much exercise we do. But another powerful source of influence is being talked about these days is the kind and quantity of nutrition you received while you were a fetus, and what was your mother's nutrition, health, stress levels while she was pregnant. So pregnancy seems to be a very important period of our lives, has the potential to permanently change how we work, and especially for the purpose of this talk, how our heart gets structured and how it actually works. Now, this topic was on the cover of the Time magazine not too long back. And certainly the idea of this talk is how we can optimize maternal health, both physical and psychological well-being, with the aim that we reduce chronic diseases, which many a times present not in the newborn or pediatric age group, but they present in the adult age group. And the focus is really on cardiovascular disease. So a lot of credit goes to Professor Barker, who looked at, from epidemiological point of view, the link between being born small at birth, which was a reflection of poor nutrition before birth, and heart diseases in the middle age. So a link between birth weight or weight gain in the first year of life and cardiac diseases, hypertension, stroke, between 55 and 70 years of age. And that data is all adjusted for lifestyle changes, dietary preferences, smoking, and all. So this hypothesis is so strong, it's been replicated more than 20 times, and every time it has come to be a most solidly replicated finding in the field of public health that maternal health and well-being during pregnancy is critical for the fetal well-being and for the well-being of that child when he grows to become an adult. So Julia talked a little bit about that, and I just want to stress that this is what we use as our go-to definition for growth restriction. How common it is? Very common. Thousands of babies, both preterm and term infants, are born every year around the world who are small for gestation age. And this is our own data looking at preterm infants. So the incidence is actually much more common than you would otherwise appreciate. And most of these pregnancies are between 28 and 32 weeks of gestation. Julia mentioned about that, so I'm not going to dwell too much on that. There are two types of fetal growth restriction, which is one is early onset, one is late onset. And of course, what is common amongst them is that the placenta is insufficient in terms of providing nutrition and oxygen to the developing fetus. Now, what happens going forward in terms of the heart? So this is how the fetus heart would look like. This is the control on the left side. You can see it's more elongated, while the IUGR or FGR heart, you can see it's very globular and the walls are thicker. Now, when we follow these infants during the after birth in the second week of life, we exactly see the same findings. These findings persist as a child between 6 to 9 years of age. And unfortunately, even as an adolescent, you can see the cardiac shape is different, continues to stay different, and cardiac function is compromised. So these are all asymptomatic children and adolescents who had cardiac changes in utero. And that's a concept of fetal programming, that from developmental origins, these changes don't just go away, even though you are not exposed to that suboptimal fetal environment. So there's a change in the shape of the heart. The heart becomes very globular. It's not relaxing very well. The blood flow between the placenta and the unborn baby is compromised. And there was a question in the chat about biomarkers. So if you do cord blood cardiac troponin, that's high in these fetuses. So there is some biochemical evidence that the myocardium is not particularly healthy. So in the books, it is described as a globular hypertrophied cardiomyopathy-like heart. Now, Sounds scary to hear, but that is how it is. And many of these, especially the term infants who are born close to full gestation, they have these cardiac changes, although they clinically are doing very well. So they stay with the mom after birth, and they go home after 1 or 2 days, or after 4 to 5 days if they're born by cesarean section, never to be seen by a pediatrician or a GP again. So we have this gap or lacuna in our follow-up of these IUGR babies who are especially born at term, and they are asymptomatic in the first few years of life. What is important to note is even in the neonatal period, now I'm talking about term infants who are otherwise healthy asymptomatic. There are 3 different studies which I've looked at. One of them is our study, 2 are from the European countries, that their blood pressure is higher compared to well-grown babies. So they're not hypertensive, but comparing the 2 groups, their blood pressure is higher. So the blood pressure tracking develops very early in life, and it gets very established by 6 years of age. So the message to the pediatricians or the GPs or to parents is these children need a blood pressure monitoring whenever they go to a doctor, and more regularly if it's found to be in the hypertensive range. So as I said, let's move from the fetus neonatal period to children and adolescents. So many of these changes, as I mentioned earlier, they persist into the childhood. If you do an echocardiogram, the cardiac function is slower, and they are not able to. So the exercise tolerance is much less in this cohort. You look at children and adolescents. Link between low birth weight and high BP continues until even in young men. So this data from cohort studies in Sweden, where systolic blood pressure was significantly higher in young men who had the lowest birth weight. If you go beyond this population, you see most of the data is cross-sectional, means in moment in time. But this Swedish study stands separate, where there's a 97% follow-up over a period of 50 years. And again, this study also confirms, including the American study, that if you are born small, then there is a higher risk of hypertension and cardiac diseases during adult life. So this is again a study from Finland, following up at 31 years and 34 to 49 years. Again, the same message, that the cardiac changes which you see in the fetal life or the newborn period or pediatric age group, they just don't go away. They persist even if you follow them many years down the line. So Julia and Rocco mentioned a little bit about the centile charts, and this is how they look like. This is the one on the left is for the boys, one on the right is for the girls, and you can see these lines which are looking at the weight, birth weight, and weight going forward over first couple of years. And for a fetus, for a baby who's born small, if they are on this bottom line centile, the expectation is as months and years pass, they should follow their centile chart. They should not be crossing lines and going up, right? So even for the girls, if they start at this orange line, they should follow this orange line as they go forward. When they start crossing this line and jump centile charts, that's when the problem arises, and that's called catch-up growth. The understanding from the parent perspective is a bigger baby, a fatter baby is a healthier baby. Nothing could be wronger. Nothing could be further from truth. And the reason is this data looking at rapid weight gain in the first 3 years. Those babies, when they grow, become adults, they don't really do very well. Similar data in other cohorts where average BMI is higher during early childhood, they don't do very well when they grow to become adults. So very important that we look at low birth weight from the angle of subsequent obesity. So these two insults put this IUGR population at a very high risk of chronic cardiovascular disease during adulthood. So what can we do to help them. Of course, Julia mentioned in detail about the management during pregnancy, but looking at the neonatal and pediatric, of course, avoid rapid increases in body weight of the small baby. Very important to have good postnatal nutrition. So breastfeeding, we underestimate the importance of breastfeeding so much, but there is data that it reduces the impact of IUGR state on cardiovascular remodeling. So that's very important. Very important to monitor these children from body weight and birth weight perspective during the childhood and adolescence and during young adulthood. And the reason why that is important is if you ask a cardiologist who's managing hypertensive adults, do they ever take perinatal history other than smoking, diet, and all? The answer would be no. So it's very important that this history is included when managing adults with hypertension. And the reason to prevent high blood pressure in this population is this, that prevention is paramount, because if these infants become hypertensive clinically, and that is secondary to low birth weight, then that blood pressure is very difficult to control, many a times requiring multiple antihypertensive medications. So prevention is key. Regular surveillance and monitoring is key. Last few slides, this is one of my colleagues who works in Spain. They've done a randomized control trial of 1,200 singleton pregnancies. These are pregnancies who previously had given birth to an IUGR baby. So this study is done in Spain. So they, of course, have the very, very standard developed country usual care, which is excellent. And they compared 400 of these pregnancies with two other groups. One is a Mediterranean diet group. I'll talk about that a little bit. The second group is stress reduction group with no change in dietary provision. So 8-week stress reduction program, weekly sessions, group discussions, meditation, yoga. Okay, some kind of mind over matter kind of thing. And what they were looking for is percentage of pregnancies which lead to a small baby, and a lot of secondary endpoints, clinical outcomes and all. So this is the Mediterranean diet program: olive oil, walnuts, fresh fruit, whole grain cereal, nuts, fish, vegetables. Seems like a lot, but it can be done. It is doable. It's just we need to be regular and we need to eat the right proportions. So this study of 1,200 pregnancies noticed that compared to the control group, the incidence of small baby being born, like growth restricted baby, SGA baby, is significantly less simply by a diet change, and also in comparison to no diet change, but a stress reduction group has a significantly lower, lesser incidence of a small baby being born. If you look at the perinatal outcomes, significantly better perinatal outcomes in both the Mediterranean diet group and the stress reduction group compared to the control group. So the take-home message, very important for the clinicians, public health experts, parents, to appreciate that a lot of it is under the radar. Subclinical cardiovascular disease begins very early in life, and there is strong evidence that it may be starting before birth. Very important to pay attention to diet and mental health during pregnancy. Avoid rapid weight gain of the small baby. Regular monitoring of blood pressure and urine protein at each GP visit. So these cohorts leak a lot of protein in the urine from very early on, and every 3 to 5 years measuring metabolic bloods like LDL cholesterol and blood sugar. So this is where I want to end. There is a lot of work being done in following these populations up into the long term, but the focus gradually is shifting onto interventions, how we can prevent these cardiovascular disease, which present in late young men and adulthood. Thank you very much.
Thank you, Arvind. That was very interesting. I particularly like the part where you mentioned cardiologists don't ask about their history when they're born. We have the same problems with women who go to a cardiologist after they've had preeclampsia. And we know preeclampsia is a big risk factor, but a lot of them don't ask that either. So we've got a lot of work to do out there, haven't we, to help improve the health of our community. But that is the end of the webinar. Thank you for keeping to time. We're just at 9 o'clock now, so I'll be really quick in the wrap up. I do extend my heartfelt thanks to Julia, Rocco, and Arvind for giving up their time to share their knowledge with us tonight. And I just want to say so that some of those case studies could have been a bit distressing for some in the audience. So if you are feeling a bit distressed about that, I would advise you to speak to someone. If you've got someone close you can speak to, you're very welcome to reach out to APEC if you want us to point you in the right direction to get some support. A big thank you to Cami for keeping the thing flowing tonight and making sure it all ran smoothly. I apologise we didn't get to everybody's questions. Perhaps we can pass those questions on and they can be answered offline, if that's all right with the speakers tonight. Cami, I'll just ask you to pass those questions on. That'd be great. And lastly, a big thank you for everyone who attended tonight. It's great that you've come along and supported what APEC does, and I just suggest that you support APEC a bit more by either becoming a member or making a donation or following us. That would be terrific. We do like to increase the size of our APEC community, and if you want more information, just go to our website, which is apec.org.au. We did record the webinar tonight. It will go on the APEC website and our YouTube channel. So if you missed some of it or you want to tell your friends all about it and watch it again, just keep an eye out on it. It takes us a little while to get it up there, but it probably a week or so and we'll have it all sorted. Cami's now going to display a QR code that will take you to a very, very brief feedback survey that we asked you to complete. Oops, she looks like she's having a bit of trouble displaying it. Oh, here it comes. If you're unable to scan it tonight, Cami will also be emailing it out to you. We do ask that you spend a couple of minutes answering the questions. It does give us a lot of really useful information to help us plan our next webinar. Like I said at the beginning, we do actually listen to what you say and try to make the next webinar something that you've all requested. The next webinar will be coming along in November this year. So yes, please do the survey. And there's just a little message has come through on the chat now saying all talks were very interesting. Thank you. I appreciate your time and sharing your knowledge. And APEC feels the same about that. So thank you everyone for coming along and enjoy the rest of your evening. And hopefully we'll see you at the next webinar. Bye-bye now.